Right, thank you very much. I'd like to build on some of the brilliant work actually by Dan and Carlo that they've just presented, and talk a little bit about an alternative approach to improving adaptive therapy, and utilising deep reinforcement learning to try and optimise the adaptive treatment schedules that we're proposing. So I'm going to do this particularly in the context of prostate cancer. Now, prostate cancer is the second most common cancer in men and the fifth deadliest. Typically, within the clinic, most patients will undergo surgery before following 1 to 3 kind of schedules of chemotherapy. And alongside that, in later schedules of chemotherapy, they will often also undergo hormone therapy, such as androgen deprivation therapy. I'm going to be focusing on that for the context of this talk. But we hope that a lot of these findings are also general to to other cancers as well. So I'm going to start by kind of giving a brief recap of adaptive therapy, as I'm sure by now everyone here is very familiar with what that is. And also talk about a little bit about deep learning and the virtual patient model that we use in this project to generate the synthetic data that we need to use deep learning in this context. And then going to go on and compare our deep learning framework to the clinical standard of care and show that we can actually outperform the clinical standard of care, as well as conventional adaptive strategies using this deep learning framework. And then I'm going to talk a little bit about how we can actually learn from the deep learning framework in terms of what an optimal strategy might be for adaptive therapy and how we can then translate that into the clinic on a patient-specific basis. So androgen deprivation therapy in the clinic is typically implemented using a maximum tolerated dose protocol. We've seen a number of these graphs today. You typically get good response to start with, where the patient kind of seems to be responding to your drug. That progress kind of stagnates, and then over time we get competitive release, and the patient will then undergo relapse. And we can kind of replicate this by a simple 2-population model with sensitive cells here in green and then resistant cells that don't respond to your drug in red. And they've got a simple inhibitory relationship between them. So sensitive cells are inhibited by treatment, but in turn, they actually inhibit resistant cells through competition. And we can utilize this network in adaptive therapy. So in the protocol that we use, which follows Bob's clinical trial, we give treatment, we consider treatment until the tumor shrinks by 50%, and then give a holiday until it grows back to its original size. Now, we actually replicate this inhibitory network through a mathematical model. We use a 2-population Lock-Volterra model with logistic growth, and we implement competition between the 2 species via a shared carrying capacity. The other things to note in this model is that we have a Norton-Simon drug response term. So the effect of the drug is specific to the sensitive cells and scales with the current growth rate of those sensitive cells. And then finally, we also have a resistance cost in this model, and that's slightly hidden, but the way we implement that is just by saying that resistant cells have a equal to or lesser natural proliferation rate than the sensitive cells. So now we're going to talk about how we go from this model to a clinical prediction of the optimal treatment strategy for a patient. So we can simulate patient data using this model to generate a complete kind of treatment trajectory based on any arbitrary treatment schedule that we want. We can actually then feed that simulated data into a deep learning framework, which we do here. And that deep learning framework will give us a treatment recommendation. So this is a stochastic decision, and I'll talk a little bit about why that is later on, because it's slightly counterintuitive, but it's a stochastic recommendation as to whether or not we should treat in the next time step. This is currently a binary treatment decision, but we could extend that in future work. Once we've got that treatment decision, we then feed it back into the virtual patient. So the deep learning model has said, yes, I would like to treat in the next time step. And then we go back to the virtual patient to predict what would happen if you then treated in the next time step for a given patient. So how's the deep learning model coming up with this prediction? Well, we use the framework on screen, and the important thing to note here is that we have some kind of global network which determines what decision is made. We then duplicate that network to create multiple identical copies which then interact with different patients. Now, they make decisions which are somewhat stochastic, and the reason for that is that then we can explore different treatment protocols. So these two identical workers interact with identical patients to give a different treatment schedule and therefore a different outcome for the patient. We can then score those outcomes looking at both the total tumor size, but also other metrics such as the cumulative drug dose given across treatment. And then we feed that back into the global network, weighted by how good that treatment was in our score. So here on the right, worker 2 appears to have come up with a better treatment protocol. The patient that worker 2 is interacting with survives longer. It has a longer time to progression, or TTP, and so therefore we give them a higher score and we weight that higher when we update the global network. Now, so this means when we train, initially we have a kind of random network that makes random decisions. And as you can see at the left of this graph here, doesn't do particularly well with a TTP that can be really quite short, very close to 0. But over time, the TTP that the deep learning network is able to achieve increases, and the variability of that decreases as the deep learning network becomes more robust and certain in the decisions that it's making. So that's the kind of overall protocol which we're using. I'd now like to show you how the results from that protocol compare to the standard of care, and talk a little bit about how we can interpret the decisions that the deep learning network is making. So this is what standard of care would look like for a single patient profile that we're using. One of the important things to note here is that we're using a 20% growth from initial tumor size thresholds for progression. That's the same one that's typically used in the clinic and was used in the clinical trials that have been talked about earlier by Bob. And we see this characteristic curve, good response to start with, and then relapse. And the patient kind of progresses in just over a year. Now we can improve this through conventional adaptive therapy based on this 50% rule that we've talked about already. And so we can actually delay this relapse by about a year in this context. I think it's about 200 days compared for the blue line compared to the orange line. But we still get relapse within about 2 years. However, if we apply the deep learning framework to the exact same patients, given the same information, we can actually double the time to progression for this particular patient. So this seems like a great result, but I think anyone who's spoken to a clinician here knows that that's never going to be translated to the clinic unless we can tell the clinician how the deep learning model is doing that, how it's making its decision, and give some kind of interpretable outcome to what the deep learning model is predicting here. And so we intend to do this by trying to correlate what's going on in this network. So the input, the current tumor size, and then the output, so the treatment probability. And so we can plot this on screen. And what we see is, this is the first decision that the deep learning network makes. It has an initial tumor size of 1, and it says, yes, I would like to treat that tumor. And we can build that up over the course of an entire treatment profile to get some kind of curve here. These are the decisions that the deep learning network has made for a single patient. And this relationship becomes more clear once we then accumulate data over 100 synthetic patients. And we can interpret that as a single treatment threshold. So most of the adaptive schemes that we've seen before are based on 2 thresholds. In the initial scheme I showed you, there was a 50% threshold that said when we wanted to remove treatment, and then a 100% threshold, so we restart treatment when the tumor then reaches its initial size. Here, we just have a single treatment threshold, N prime. If the tumor is larger than that threshold, we should give treatment. If the tumor is smaller than that threshold, we should withdraw treatment. And we can actually interpret this in terms of our competition model. So what we're trying to do here is we're trying to maximize the sensitive population while ensuring that within the next treatment decision time step, we will not reach progression. And we can derive, based on this inspiration from the deep learning model, we can derive an analytic expression for the optimal value here. That's quite a complicated expression. You've seen kind of most of the terms before, but I'm not expecting anyone to have derived that in the last 30 seconds. In fact, the whole point is that this is a complicated expression. And yet what we see is that the deep learning model is able to almost exactly replicate the numerical value of this expression with no knowledge of the underlying mathematical representation of the model. So the dashed curve here is very close to the steepest part of the solid curve, which is what we observed from the deep learning model. And this prediction doesn't just happen in one case. We can also replicate this with multiple different decision frequencies. So if we get the patient into the clinic every 2 months or every 4 months, we still get very accurate predictions for the deep learning model able to replicate the optimal strategies. Now, the other important thing to note here is that this expression for n prime is highly dependent on the patient's parameters. We've seen a lot of talks today about what the best form of adaptive therapy is, but this is suggesting, well, maybe there isn't one best form of adaptive therapy. Maybe the adaptive therapy protocol that we should implement should be personalized to the patient itself and is dependent on their parameters. And this is actually something that's really important. We want to translate that to the clinic. I'm going to show you that there's actually, in the last 2 or so minutes of this presentation, there's actually significant variation between patients we see in the clinic. And I'm going to propose a way in which we could potentially translate this deep learning framework into something that could be used in the clinic. So these are some example patient data sets that we have from Bob's trial. And we can see that these 4 patients have responded in completely different ways to treatment. Now we can actually fit those patients to the virtual tumor model that we have and get some idea of their characteristics. And we can then combine that from an entire data set that we actually take from the Brukovsky trial, a Canadian phase 2 trial in prostate cancer, to replicate this in cost turnover space. We've already talked about cost and turnover. Cost is simply the cost of resistance that we have in our model, and turnover is the ratio between the death and proliferation rates of our species. And so our protocol, very quickly before my time runs out, is that we want some way to get this information about each individual patient before we start treating them. Now, when a patient comes into the clinic, we have no idea how they're going to respond to treatment. Previous kind of work here has looked at the entire treatment history of a patient. When a patient comes into the clinic, we don't have that information. So we propose here a probing cycle where we give a first initial cycle of this 50% adaptive therapy rule to get some idea of the patient's treatment response characteristics. We then fit that to the virtual patient model that we're proposing. We retrain our model on that virtual patient that's personalized to the patient we've seen in the clinic to fine tune our model to their individual characteristics. And then we follow up on our treatment with that model. And using this framework, we can see significant benefits for all patients in our test data set relative to both a simulation of what we think those patients should have achieved under continuous therapy, the standard of care, and also what those patients really achieved in black in the clinic. So in conclusion, I've shown you that our deep learning framework can outperform clinical standards for patients. I've shown you that we can get interpretable decisions from these patients that can inform optimal treatment strategies. And I've hopefully outlined a way in which in the future this could potentially be implemented in the clinic. Thank you very much for listening. I'd like to thank my wonderful supervisors, Sandy and Philip, as well as Bob at the back here, and also Maxi, who a lot of this work is based on. And please also check out our preprint. It's got a lot of other cool results about how actually the frequency with which you treat matters and how robust our model is to variation in patient parameters. Thank you.
Time for one quick question or two, if anybody wants one.
Hey, Kit, this is super cool. I really like it.
Thank you.
I have one comment / question. So, I mean, talking about sex differences in cancer, I mean, we are talking about prostate cancer, which is kind of restricting the population. And given that you already, in this particular model, paradigm, however you want to call it, you already see quite a lot of variation in between patients.
Yeah.
And I'm wondering if you want to extend this work and talking about some tumors that will be omniscient to different sexes and genders, how many different tumor samples would you be needed to collect in order to properly predict the future dynamics? Because you already see a variation in this restricted sample, but if you extend that, I could imagine that would be very costly, and you potentially may not encounter for some outliers, some patients that are not falling into the typical ranges of parameters. So how do you think we can deal with that?
Yeah, that's a great question. So there's, I mean, as we've seen from kind of some talks today, there's massive demographical differences between how certain patients respond. I think actually also those who saw Alex's poster yesterday, she presented some really cool results about how patients of different racial demographics differ in response to treatment. And that's kind of one of the things that's motivated this work. So I think the key here is that we're personalizing to an individual patient. So we don't want to necessarily recommend one treatment schedule for men and one for women, for example. It may be that we see that, for example, I don't know, men tend to cycle faster and so require more frequent evaluation. But the hope is that this will be personalized. And in terms of then having data sufficient to do that, obviously you have a sample size of 1 at that point. And then the key is, if I just go back, this probing cycle, where instead of estimating that we have kind of these parameters for a tumor for men and these parameters for tumor for women, we can use parameters that's tailored to an individual patient based on how they respond to the first cycle of treatment.
Okay, cool, thanks.